I'm Ryan Carlson with HealthJump. I'm here with two amazing gentlemen that are doing some cool stuff with health data. We got JJ Richa and we've got David Lanzkowsky.
Thank you.
And you guys are from Quality Care Metrics, and tell me, what is it that you're doing? What's the name of your software?
The name of the software is Deep Empathy, and what Deep Empathy does, it enables physicians, patients to communicate better, and if patients communicate better, it develops a sense of trust. And when patients trust you, they're more likely to tell you, openly communicate with you, and then get you a better diagnosis. So my background is in anesthesia and pain management. I've been treating patients with chronic pain for over 25 years, and we've been using these emoji scales and numeric rating scales, visual analog scales, 0 to 10. And based on that, I have to, write prescriptions, do procedures, and things like that. And there's really no objective measure for pain. It's all very subjective.
Absolutely.
So in 2016, the CDC basically put out these guidelines for weaning patients off opioids. And we started to do that, and that was just like an exercise in futility. One of the patients one day says to me, "You don't really know what you're doing, do you?" And I'm like, "Of course I do. I'm board certified. I've been doing this for 25 years. I know exactly what I'm doing." He said, "No, you don't." So I threw him out of my practice. I was all mad at the guy. "How dare you insult me like that?" But I drove home and went to sleep. I woke up the next day and I said, "This guy might be right. I don't really understand pain that well." So I set about finding what was available to better understand pain. And there really wasn't a lot out there. So I started using my own experience treating these patients, and I knew that they suffered from a magnitude of comorbidities, and those included stuff like pain behavior, pain interference, sleep, anxiety, depression, relationships with people, efficacy for managing emotions. So we put together 16 data points into an interface. So a patient would come in, we'd give them a tablet, a laptop, they'd fill out the information, and then we'd have this graphic interface so the physician could just look at what was going on and they could start making determinations as to who they were talking to. It's almost like a peek into the patient's soul.
I got a question to peek into your soul. At what point does JJ come into this story and you guys go, some guy told me I was wrong, and then I thought about it, maybe he was right, and then I've got an idea.
So we started to develop the software, and actually my son's in Silicon Valley, and he says, "Dad, you might have a startup." And I'm like, I didn't even think about that. So JJ's with an incubator group at UCI, and we were put in touch with him and JJ, and we've been together since the inception.
What did that first meeting look like?
First meeting was interesting because we didn't know what we were looking at first, but as soon as you start understanding better what Dr. Lanzkowsky has done, you could tell that it was unique. It's one of those things where no one's done it before, because none of the domains that we're looking at, the 16 domains, ask questions directly about how are you suicidal? What's your pain level, 1 to 10? It's questions around the subject, and so they can't trick it. It's an adaptive responsive. So if you answer a question a certain way, the next question is maybe different for you than me answering that question.
So what is the market and who is the customer? Like, who is your customer that you are taking this idea and concept to?
So the customer is really clinics. And mainly we're concentrating initially on pain management clinics. Now we can go, so the 16 domains we're starting with, they can grow into potentially hundreds of domains, and we can go into other areas. But initially we're starting with this. And really we have three value propositions for these clinics.
Okay.
The first value proposition is what Dr. Lanzkowsky just talked about, is that better communication, the trust between the patient and the provider.
Question about that.
Yes.
Right? Because then we got two more pillars. So
yes,
I'm not going to lose that.
We're not losing.
But the better communication, is that just changing the dialogue from "are you" on a happy face emoji, or is it just like having a better language for talking about how you're feeling?
So it opens up a whole, like the conversations have completely changed. And my attitude has completely changed towards how we treat patients. In the past, before we had this guys doing pain, really patients would come in and they'd have basically 3 decision points. Am I going to do a procedure? Am I going to write a prescription? Are you potentially drug seeking? Am I going to toss you out of my clinic? Or I'm going to order an MRI. And the diagnoses we were making prior to using the software were all anatomic diagnoses like degenerative disc disease or lumbar spondylosis. After we started using this, and this is like with almost near 100% change from everybody using it, was like The diagnosis then became chronic pain, opioid use disorders, sleep disorder, depression, anxiety.
It's like when the DSM started adding more and more spectrums rather than one clinical diagnoses, right?
That's
a better way to talk about how you feel, how you're reacting, your cognitive decision making process.
Exactly. And then something really interesting happened was my practice manager came to me and she said, look, you're spending, we're falling behind in the clinic. We're spending a lot more time with patients.
Too many, lot more questions,
yeah,
right?
Longer questions, more time, just much greater connectivity. Like this conference is about connecting
data.
Yeah. Right? So we're really connecting physicians and patients. So interestingly, what happened was we stumbled into a CPT code that we submitted that is actually covered. So we didn't. So then we started getting reimbursed for what we were doing.
For that diagnostic intake,
yeah.
Effectively,
yeah.
Right?
There's mental health code
assessment.
Yeah.
Oh, that's fantastic. So that's pillar number one is the communication. I love
Yes.
hearing your examples. What's pillar number two?
So pillar number two is mitigating risk. So these clinics,
Yep.
mostly they're sometimes prescribing opioids, and they don't know that, because the patient is saying, I'm at a 10. And you're at a 10, I'm going to prescribe more.
Who's to tell me that you're not at a 10?
Who's going to tell me you're
exactly.
not?
Yep.
So, and then so they're putting themselves at risk of maybe potentially losing their license, or
Yep.
so that's pillar number two. Pillar number three is what Dr. Lanzkowsky just mentioned, which is the reimbursement. So it is now increasing the revenue, the net revenue. So it's an additional revenue per visit that the clinic can collect, and that revenue ranges anywhere between $60 and $200, and it could be more depending on many other factors. But so if you think about it from the standpoint of a clinic that usually gets $30 to $40 per visit,
Yep.
now they're getting an additional $60 or maybe $100 for that visit. It's really huge.
And so it's not just, what I'm hearing, and please hear me out.
There are three really big things.
Right, but that third one though, if heard wrong, it could sound like, yeah, there's an extra claim code you can use and make more money, but it's not a money grab. It's getting paid for actual value that intervenes and reduces risk to patients, right?
Let me add two things to what JJ said as it relates to risk. You have risk of getting sued as a physician, but also if you give the wrong dose of opioid, either too much or too little, you've now risked the patient's outcome. So if you give a patient too little opioids, they're going to oftentimes just find medications in the street that could be cut with fentanyl, overdose and things like that.
Self-medication.
Right, and if you don't identify an actual drug seeker, you've lost an opportunity to get that patient help.
Yeah.
So you decrease the risk for patients. Now the beautiful thing is about the reimbursement is it then allows you to spend more time because we've actually changed our scheduling. So we used to see 4 or 5 patients an hour maybe.
Yep.
Now we can comfortably see 3, spend more time with them and not lose money. If we like with those low reimbursement rates, if you spend, if you're doing a 99213 visit, and they're, depending on who your payer is, that could be, $35 to $60 for that, for that code. Mm-hmm. And the MGMA now is saying it costs you about $60 to get a patient in your door. So
you're losing money.
So you're literally losing money
So
if you don't hit a certain number of patients. And this, but this allows you to see less patients, make equal amounts of money, deliver better care, and staying in business is important, right?
It's the, secure your own mask before securing the mask of others, right? You can't help others if you're not there to be of assistance. And so the business case makes perfect sense to me. I'm married to a provider who is an independent provider of services, so the whole claims code and not getting paid for the valuable work you're doing, totally makes sense. So Ryan and my empathy level, very high. I would love to hear if, we're talking about data, you're using data to go into this diagnostic model. Tell me what the unique aspects of your diagnostic model and your software is doing. So business case makes perfect sense. Why we're doing it makes perfect sense. Let's talk about the solution a little bit.
Sure. And just to add, and just step back 1 second, it makes perfect sense for the insurance companies because about a third of diagnoses that we do are incorrect. So it's a delayed diagnosis. So the insurance companies, for example, and I'll show you in some of my examples how we save insurance companies money. if somebody comes in and they're complaining of back pain, but it's some other kind of psychosomatic problem, like loneliness, for example, the right solution might be getting the patient a service dog, not getting an MRI and a spine surgery.
So this is also kind of like that principle of measure thrice, cut once.
Exactly.
Right.
That's
Yes,
where the savings
that's right.
come into play.
Absolutely.
Yeah.
Oh.
And no, the savings are enormous, because if you can look at the software and see that somebody's, all his domains are lighting up red, and you do a procedure on that patient, your outcome's going to be guaranteed to fail.
And the models that you've created, that you were telling me earlier, like the efficacy is very high. Like, could you share a little bit about like what the aha moment or the validation looks like?
Yeah, we have a patient comes in and sees me. She tells me her pain score is 9 out of 10, and I run her through the software, and all her domains are green. And by green, I mean they're normal, within normal limits.
Yeah. Mm-hmm.
So, having done this 30 years, I knew it was virtually impossible to have no comorbidities associated with a pain score of 9, whatever that means.
Yep.
So I said to her, "What's going on here?" And she says, well, I just came from my attorney's office. I had a slip and fall, and he told me if I told you, pain doctor, my pain is a score is a 9, then I'm going to get a better reimbursement. And then she says, actually, I don't have any pain. So that was a diagnosis of malingering, which I've made very few times. It's a pretty hard diagnosis to make, but the software just immediately led me to that diagnosis because I had information and communication that I never previously had. Another patient comes in, he tells me his pain score is 0 out of 10. I put him through the software, pain interference is lighting up, pain behavior is lighting up, he can't sleep. And I'm like, what's going on here? How can you have a pain score 0 out of 10? And he says to me, well, I've lied to you, doc. My pain score is, I don't know, maybe it's a 7, but I need to get back to work. I got kids to feed, and if I tell you that it's a 7, you're going to put me on work restriction, and I'm going to lose my job. So, so that's pretty fascinating. We've had patients come in, and we put them through the software, and we can see that maybe they're on opioids because they've had failed spine surgery. And we can see if the dose is correct, because you can see that if their sleep is good and if their depression, anxiety, relationships with people are all good, but their pain interference and pain behavior are like just slightly orange, yellowish red, that they're not going to use their opioid for, the commonly reasons that people misuse opioids is depression and anxiety and sleep.
Absolutely.
So that he's on the right dose, and you don't really need to make changes. You can continue there.
Because those things aren't the problem.
Right.
That's really fascinating. Because sometimes I feel like it's like a titration guess. It's like,
it is a guess.
You're at 40 milligrams, let's try 50, right? But not knowing that there are far more unintended consequences of going in either direction. It sounds like your model isn't just on the pain scale, but it's the other things that happen, right? Like our bodies react to medications of all kinds of very different ways. And this seems like it's a way to diagnose what's happening. Even if pain is being managed, you might cause other consequences.
Yeah, and that's exactly, the word guess is exactly right, because that was the frustration. Yeah, that was the frustration I was having. I was going to work and basically guessing, and I'd come home going, prescribing opioids, I'm guessing.
Yeah.
Because there's no better tool.
Did I do it right?
Walk me through just the brief elevator picture of what the patient experience looks like.
So the beautiful thing about this is the patient comes in, they can take a link, they get a pain diary, basically what we call brief pain inventory, which is a traditional brief pain inventory where you click on where it hurts, what your traditional pain score is with or without medication.
Right, the X's on the elbow or the neck or the
exactly.
Yeah.
We've all done that. Over and over.
And then we give them a series of questions. Questions goes up to the cloud, it's scored, it comes down, it's put into a nice interface. And the great experience is that I can, like in the past, I used to be sitting here typing, looking over my shoulder, so where does it hurt, and I'm just distracted using the EHR and talking to the patient. So
because
now,
you're mainly, all you're doing is trying to take notes.
Right, like data entry.
Of the transaction.
Right.
Versus actually talking
now
to
there's a high value skill in the middle of, like all I'm doing is capturing data.
Right.
And,
so he doesn't forget.
Yeah.
I know.
Well, the biggest thing that physicians are complaining about nowadays is what's called EHR burnout.
Yeah.
Because that's all they're doing.
So,
and this opens up that communication.
So they're in the waiting room, they receive a link. Are they, so they're taking this thing?
Could be home. We could send it to them
so
at
they,
home.
So they can do it in advance.
They can
before,
do a telehealth via telehealth
awesome.
visit.
Yeah.
So this is enabling the data capture for all of the telehealth that's
Right.
out there
You
as
can
well.
do it that
That's
way.
fantastic.
And then what I like is if when they come into the clinic, we give them an iPad, it's on a stand, they fill it out in the waiting room, and then the data is then transferred to my EHR. So instead of sitting there with my back towards the patient, I literally, now we've put our screens on a, like a wall mount,
Yep.
So now I have this patient come sit next to me, I'll put the wall mount in front of them and I'll just be like, hey, let's go through this. And I can talk to them, and oftentimes I don't even have to open my EHR. I don't even need to go into it.
So you're just,
Because
you're
they're
just-
looking
you're
at the
bringing up
results.
the results
Yeah.
and the
Right.
dashboard.
Yeah.
That's
and I
right.
don't have my back towards the patients, and the patients, some of them are going, oh, can I print this? I want to stick it on my refrigerator and follow it. So we've had great patient response. They feel listened to, they feel heard, they feel, empathy, and
It's not the adversarial, I'm telling you what I think you need to hear
I wanna
to
hear
give me
what
the
you-
outcome that you don't know that I want.
right. And let me give you just a great example. Is I walked into a patient the other day. I opened up my deep empathy software. I looked at it and I saw anger flashing. That was the biggest thing on her. So I said, "Oh, I see you're really angry. What's going on?" And then she starts saying, "Well, your staff did this and your staff did this, and why can't you schedule on time?" And she's just complaining. And I said to her, "Look, don't blame my staff. Don't blame schedule. It's my fault. I had a call. I was inconsiderate of your time, and I apologize." And she's like, "Oh, that's great. That's all I wanted to hear." And then our visit just went swimmingly well after that. But it was the ability to just walk in there and just look at a screen and understand the emotion that was predominant.
Yep.
And addressing that immediately, and then just communicating like I've never done before. And what the other thing this has done is I was literally ready to quit. I had such burnout that I hated going to work. I just felt like, I'm doing data entry. And then with this, I really enjoy going to work and seeing patients again. And that's been transformative for me.
Yeah.
Having done it this long, I'm like, I don't walk in there thinking, oh no, what does this guy want? Does he just want drugs or,
Yeah. Well, so HIMSS, they're talking about, connections. And
Data
they're talking about data.
connections. We're talking about humans.
I'm talking about humans, which is also the ultimate goal.
Yeah.
Actually,
So-
there was a conference, a speaker that talked about empathy
Yeah.
during the
Yeah,
conference here.
there was one.
Well, Dr. Lanzkowsky, I love this idea that not only are you walking this journey literally side by side because you're sitting down and going through this, that you're changing the conversation of how am I feeling, how is other factors in my life, mental, physical, behavioral, all impacting this terrible one-dimensional concept of a pain scale, right? And turning it into a conversation and not just a guess,
Right.
diagnosis, and then
Guess
measurement,
again.
right?
Measure a guess, yeah.
I mean, that type of process is just an ongoing science experiment that you may that has no real good control, right?
Right.
You don't know if they're going to do it on time.
No.
There's all this great remote patient monitoring and remote accountability that programs are having for like diabetics and for physical therapy, but for pain, it seems that all we hear about is the extremes. People that take too much of the medication aren't taking it at all, and there's no real good way to know, well, what really is the problem? You're not sleeping enough. You should be exercising more. You're angry, and then it's at me. I'm sorry, right?
Yeah.
So
I want to mention a couple of things that we didn't mention. So we actually track a history of the treatment. So Dr. Lanzkowsky, or the provider, puts a treatment plan in place.
Mm-hmm.
So we track that. They come back again, we give them the assessment again. And then we keep track of it from beginning to end. So you could see an entire history after 6 months, 9 months. You could see if they're improving or not improving. And so with these graphs, and on all the different 16 domains that we have them on the software. Each one is a different color, and you could tell, are they improving or are they really digressing? And that's really huge. One more thing I want to mention, it is NIH approved, what we're doing. Okay. So it's not just like out of the blue that this is, we just came up with this. So.
Well, the results and the actual human stories, to me, makes perfect sense, right? It's one thing to go like, yeah, we did this thing, it helps with connection and improves communication. But it's clear that this is actually a meaningful change in patients' lives, and it's by just changing the literal conversation. This is a drinking game. I should, every time I say literal.
Yeah,
We're just all people here, and I'm so excited about what you guys are doing. So tell me, what's next for quality care metrics and for your software? Is this something that people are going to be buying licenses to? Do they get trained in how to use the rubric? I mean, what does that look like?
I'm going to let JJ take that one.
So we have a full manual that user manual that basically trains the medical assistant. It trains the provider on how to read, how to assess. Because after the patient takes the assessment, and then the provider is presented with all these graphs, colorful, and they need to interpret them. And so unless they interpret them properly, they're probably going to misdiagnose. They're probably going to not have the right treatment plan. So what happens is Dr. Lanzkowsky, and we have videos around it where we actually train them. So that, and the provider needs to really do it they can't do it for a day or two and say, okay, I'm done. They probably need to do it for a couple, 3 months to really get a better way of understanding it, so they're able to quickly look at the graphs and say, I know what's happening here.
There's a learning curve to it for the physicians.
There's a little bit of learning curve.
Yeah, but what happens after you do learn it, it's like computer vision and pattern recognition. You can just see what's going on. It doesn't take that long, but in the initial uptick, you need to spend lots and lots of additional time. But once you get to that pattern recognition stage, you can process the information pretty quickly, which is great. And the patients have been, for the most part, very accepting. A really interesting story is that when we started with implementation, there's a lot of complaints from the staff and the patients, and it's something new. And so we started tracking complaints, and we did, I would go into the office and I'd hear complaints. Everybody's complaining. Nobody wants to do it. So we started tracking if there's any truth to this. And we did 1,000 patients track. We found 70 complaints, which is 7%, 3.5% were internet-related problems, like they'd lost a signal or something. So we're down to 3.5% complaint rate. When we divided that 3.5%, what we found was half of those complaints were just really questions like, why do you keep asking the same questions over and over?
I already answered that question.
Just simple stuff like that. But the other people, they had kind of like more vague complaints. And we started drilling down on those vague kind of complaint patients, and what we found was they were all on high-dose opioids, and none of them had actually followed through on a treatment plan. So it started to identify potential drug seekers just by the minute you just complain, we can start to see what's going on.
And now you know the rest of the story.
That's right.
That's the thing I wish we had more opportunities just in general when it comes to people like, oh, but they didn't like it. Oh, we better change it. Well, why? Right? You go to the Toyota methods, the 5 Whys and Kaizen and all that fun. It works for a reason, and I'm so glad to hear, and actually I'm not surprised in healthcare that we'd have an actual doctor asking diagnostic questions about why we're feeling this way. So how could people learn more about what you guys are doing?
So they can go to our website, qcm.ai or deepempathy.ai, and they could learn more. What we're doing also, we're marrying the assessment with intake forms right now. So most clinics, they're still on a clipboard. So we're able to digitize those intake forms, and together with the assessment, so they're one piece. And so that allows the clinics to be able to receive information from their new or existing patients and do the assessment at the same time, and be able, and then what we're doing is we're adding some intelligence to it, so we could find out exactly which CPT code fits for a very specific, for each patient and what they're doing. So that way, it is kind of an end-to-end solution for the clinic with minimal interference from the staff.
So what people can expect is their own diagnostic session to hear what their pains are in their practice process, and how it is that you'll meet them where they're at in their journey to improve.
And the data that we can gather is really important in terms of trying to predict what medications are going to work, and then you can start creating new drugs micro-dosing and combination drugs. So
Is that the next step?
I'll add one more thing. We're adding some digital therapeutics to it.
Yeah.
As well. So it could be somebody stressed out,
Yep.
and then we'll give them access to a digital therapeutic that helps them, maybe relieve that stress.
So there's clinical decision support that we've built into it, and the algorithm basically starts with the conversation, getting a diagnosis, and then we push people to digital therapeutics. And then after that we start talking about medications, because like so many of us have trained where everything's a medication, right? So you go straight to a drug, and then oftentimes, you're dealing with side effects, or the drug didn't work, or an allergy, or whatever it is, and then you're going back and forth to the pharmacy with the wrong dose, the wrong drug. So we start out with a digital therapeutic, and we try to follow that they're actually using it, and then if they're not improving and they're using it, then we might add some low dose drugs, and we can do combination drugs that way as well.
Is there any other data that is needed to help inform this picture? Is there like patient histories, or is there other things that you use it within your own? You've got your EHR and you've got your system right here, so you have the opportunity to pull all those things in together. Is there a future in which you see more and more of these two worlds coming together, the other clinical information that doctors have?
That's a great question. I mean, if we can, like right now, I don't actually go into my EHR that much when I use the software, because I don't have to. So I can get all the data that I need right there in front of me. So if I'm going to my EHR, it's maybe just to write a prescription or check an MRI.
Yep.
So the information is just sitting there in the EHR. It really becomes a repository of data, that's not sitting on this platform.
So are people referring then to you? You're a referral from a general practice or someone's primary care provider?
So we get referrals from primary care guys looking, just for pain care in the traditional way. So we're not getting, we've had actually some attorneys have sent us some patients wanting us to run them through the software to make
sense.
Yeah, because they don't want to put a lot of time and effort into like a workers' comp claim or slip and fall claim if they find out the patient's malingering, right?
Yeah.
So we've had some referrals specifically for that.
Do you ever see yourself in any sort of, where the companies have their payers, and the payers always have these programs like gym memberships and basically things to improve overall health of those employee populations as a benefit? Do you see there ever being as a payer, we know that when people go through this process, one, they spend less on opioids. It's harder to trick the system and then have a relapse and then cause greater damage further on. I mean, now I'm just trying to think of it from the market perspective. What kind of exploration have you had outside of just trying to win the hearts and minds of other pain management providers?
So we look for channel partners, and the obvious channel partner would be a large EHR company with a marketplace. That's low-hanging fruit, right? Yep. And then their Veterans Affairs would be a great target for us, because really they have a lot of problems with suicidality, PTSD, opioid addiction. So this is, would be an ideal tool for them. And any large organization who wants to just do following population management. The other people who are doing accountable care organizations where their mandate is to lower healthcare costs,
Absolutely.
right? So if you can get the diagnosis right through empathy and communication, you're going to lower healthcare costs. It's estimated that a third of healthcare costs are just spent on the wrong diagnosis. And
there we go.
This is over $3 trillion, right?
I've been trying to make this connection. I know there are people that are trying to make healthcare better, more efficient, and get to outcomes sooner and prevent those misdiagnoses. Whether it's diabetes or opioid abuse, right? And having those interventions early on makes sense. And if the accountable care organization had the ability to mine their own data to identify high-risk patient populations, and they identify the high-risk patient population for abusing pain management or their symptoms, it could even be looking for I could see them actually saying, here are the types of symptoms that might be something we want to throw in this diagnostic, use this code to narrow it down. I just love what you guys are how you're changing the conversation. So
I mean, if you've got a certain set of employees who keep calling in sick, you're running through that. You'll figure out a bunch of stuff.
You need to talk to the those people that work with companies that do like the employee screenings, and then they, are they going to steal from me? Are they going to
Well, I'm
they
not
do
sure
those,
we can predict that yet.
No, they can. When you do the psychological profile and does the progressive dynamic question answering, and it's looking for work habits, not health and
or maybe behavior.
There are certain domains in there that really kind of address that, like self-efficacy for managing emotions.
Yeah.
Those domains kind of address what you're just talking about.
Sounds like it's a world of possibility. Thanks, guys, for coming and telling me, Dr. Lanzkowsky. Thank you for sharing your stories. JJ, I wish you guys the best of luck with your endeavor.
Appreciate
it. And again, people can check out your website, and we'll, at the end here, we'll have a couple of screenshots of the software that we were talking about.
Great. Thank you so
Appreciate
much.
Thank you, gentlemen.
Thanks for Health Jump as well.
Thank you.
Yeah,
Thanks.
absolutely.
Take care. Thank you.
You got it.